Man, woman, birth, death, infinity.
Good afternoon, and welcome to the Your Health radio and television program on the radio at AM 1240 KNRY, AMP's cable television channel 24, and on the web at www.ampmedia.org. Join our rotating host and their informative guests live every Monday afternoon at 4 o'clock. The purpose of the Your Health radio and television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so pleased you could join us today. My first illustrious guest, Dr. Kathryn Guggenheim, neurologist. Dr. Guggenheim, thank you so very much for coming on the program.
It's my pleasure.
Dr. Guggenheim, a lot of people have misconceptions about exactly what a neurologist does. Why don't we start off by talking about what your average week is like? Do you see patients in the hospital? Do you have a clinic in your office? Tell us what your job as a neurologist involves.
It's a bit of office and hospital. So I do a fair amount of call at the hospital in the emergency room and consults on the wards, and have a regular practice of scheduled patients during the day.
Well, Dr. Guggenheim, that's very interesting because that's a great segue. Why would a neurologist be called to the emergency room, or what sort of patient will another doctor ask you to see in the hospital?
Well, I have to say the majority of cases are headache and stroke, or what looks like stroke, and seizure. But many of the things that look like stroke turn out to be other diagnoses. So it's varied.
Okay, so by definition, the word neurology means the study of nerves. So you're the expert in the nervous system, the brain and the spinal cord and the peripheral nervous system. So that's a huge area, isn't it?
Oh, it is. It is.
So, Dr. Guggenheim, let's talk briefly about, before we get into our important subject today, which is headaches, which is incredibly important that we talk about and teach our audience. Let's talk about how one becomes a neurologist. Let's talk about your training to become a neurologist. How do you get there?
Well, medical school, internship, and then an internship in internal medicine, and then a residency in neurology.
Okay, so of course after high school you go to college, you get your college degree, and 4 years of medical school, and then after that internship and residency in internal medicine. So you become a completely trained internist.
No, it's an internship in internal medicine and then neurology. So you don't become an internist. Okay,
so you do an internship that is hospital-based, and then you have how many years of neurology training?
3.
So 3 years, that's all you do for 3 years is study and learn and treat people with neurologic problems.
Right.
Well, that's amazing. And I see that you are board certified in neurology. Well, that's a mark of excellence. That's excellent. And how long have you been here on the Monterey Peninsula, Dr. Guggenheim?
A year and a half.
Great. How's it going?
It's fine. It's fine.
Well, I see you plenty of times making rounds in the hospital, and oftentimes I get called to see an injured patient as a plastic surgeon in the emergency room, and I bump into you. You are one hard-working physician, and I appreciate you coming on the program. So, Dr. Guggenheim, what I'd like to teach our audience today, and of course this is my opportunity to learn, this huge topic, this nebulous topic, the headache. Can we start off by defining what we mean by headache? In other words, do we exactly know what a headache is?
Well, there are huge tomes written about headache, and it's a very scholarly field, and there are many neurotransmitters, and there's an elegant, complex literature. And most of it is really focused on migraine. So there are, and special headache syndromes. So there are some rare syndromes, hemiplegic migraine and cluster headache and ice pick headaches and variant headaches that are well discussed in the area of these primary headache disorders. And then there are a large number of other headaches that are also common and perhaps less well discussed in the treatment literature. For instance, post-surgical headache is an area that I've become interested in lately. And headache from subarachnoid hemorrhage. That's, I think, very fascinating because patients can be left with crippling headache after surgery and somewhat not paying much attention to.
Okay, well, Dr. Guggenheim, before we get to that, and that's fascinating to me, there's the common headache. I mean, I think we'd be hard-pressed to meet someone over the age of 21 who will say they've never had a headache. Right? So every person in the world at one time or another experiences a headache that may be self-limiting. It goes away by itself. Sometimes people will take an acetaminophen or an ibuprofen and the headache goes away and we go on with life. So that's different than what you call a migraine headache. So can you define a migraine headache for us?
Well, a migraine headache is a recurrent headache. And it has certain, so it's a headache, the International Headache Society has criteria for migraine. So it's a headache that's occurred at least 5 times over a period of so many months. And it has qualities of being throbbing, of being associated with nausea, perhaps vomiting, and of having what we call cortical irritability. And that is that some sensory modality, usually light or sound, makes the pain much worse. But also head movement or any body movement could make it worse, or smells could be irritating. And you have to satisfy those criteria to qualify as a migraine. And then, of course, there are tension headaches. And so for a long time, it was thought that tension headaches were headaches that were not throbbing, didn't have nausea or vomiting, and didn't have this cortical irritability, and were characterized by lots of muscle tension. But then they found out, quite oddly, that the muscle tension was higher with migraine than it was with tension headache.
Now, what do you mean by was higher? You mean a higher percentage of people?
Well, the degree of muscle spasm was that when they measured it with surface EMG, was actually higher with migraine than it was with quote unquote tension headache.
Okay, well, Dr. Guggenheim, now when someone has a migraine headache, what's actually hurting? Is it the skull? Is it the lining of the brain? Is it the dura? Like, what is hurting?
Well, it's meningeal vessels are causing the pain. And it's thought that there's a trigger in the brain stem that causes this. So there's still a huge amount of confusion in the public's mind that it's a vasospasm and vasoconstriction. And there were theories back in the 40s that it wasn't vasoconstriction, but a depression of the neurons that spreads across the brain that was the cause of much of the phenomenon we see. So there have always been these theoretical battles as to what the basic mechanism was.
Well, do we know what the basic mechanism was? You said, is it the meningeal vessels? If it's not vasoconstriction, but I want our audience to know. What we mean by vasoconstriction is vessels are collapsing
Right.
and squeezing closed, and a vasodilation is when a vessel will open.
Right.
Now, the meninges, or lining of the brain, there's thousands of vessels, tiny vessels. Now, are they going into spasm or dilation to cause a migraine, or is that related to it, or am
Well, they're also vasoactive or neuroinflammatory peptides. So they're multiple mechanisms, and it's not, there's not total consensus.
Okay.
And that's one of the big problems. And if you look at the number of medications that work for migraine, it's hard to imagine why it is that such a wide diversity of medicines work for migraine.
Okay, so that's going to be the great segue. That's going to be my next question. But before we get to that, the word migraine, does that really come from hemigraine, like half the head will hurt or half
Right.
the brain? Is that true when a person says they have a migraine? Is it really typically restricted to half the head or one sphere, or is it all over? Diffuse pain.
Well, the classic migraine was a hemi, but we now know that perhaps 20–30% of headaches of migraines are the classic migraine with the hemicranial pain. And many people have what we call a common migraine, and it's actually bilateral.
Okay, so far I've learned that there may be different causes to what we call a migraine headache. The cause is not entirely understood, but it may have something to do with the tiny thousands of vessels that are part of the lining of the brain. You said there are neuropeptides, which are tiny little proteins that may in some way irritate the neurons, is that right? Okay, so since we don't totally understand what a migraine is, how do you treat a migraine? If you see someone who says they get migraine headaches or they were sent to you from the emergency room, how do you start?
Well, there are two general approaches to migraine, and one is to treat the individual headache. So people who don't get to the emergency room are usually people who have had success with aspirin, Tylenol, Advil, or who use Excedrin or Furanol, or medicines with caffeine in it. But the people for whom those medicines don't work often will go to their GP and they'll get one of the triptans. And those are very expensive, very powerful medicines that will get rid of individual headaches. But the people who end up in the ER are people who have headaches that have gone on and on and on, who are really exhausted. And
I understand that people can get a migraine headache and they have to go to their dark bedroom with an ice pack or a warm pack, and loud sounds make the headache worse, and light makes the headache worse. I mean, they're just about incarcerated in their bedroom for more than a day.
yes.
So those are the people who may come to the emergency room,
Yeah.
and then their pain can be treated with a narcotic, or how is their pain treated?
Well, I'll say this, rest is nature's cure for a migraine. So people go to their bedroom for the rest and the quiet, hoping that they can get the sleep that will cure them. But sometimes the pain is so bad that they can't get the sleep, and then they go to the emergency room. So sometimes we put people in the clinical decision unit, and sometimes we just give them sedation and give them deep sleep, and that will help. But if you give the narcotics, they very often just get rebound pain with that. So the narcotics are not a good solution for pain.
Okay.
So usually what we do is try and get them comfortable enough, and if we're lucky, help them get a deep sleep so they can go home, and then start them on a prophylactic medication and work with them to get that medication to a level where they stop getting the headaches in the first place.
Okay, so prophylactic medicine, that means something that may prevent or help diminish or prevent the headache from coming on, or the migraine from coming on.
Right.
Now, Dr. Guggenheim, you started to talk about the muscle tension and the muscle almost spasticity that some people with migraines can experience. Now, most of my audience knows I'm a plastic surgeon and I use a lot of Botox in my practice. Now, I understand that you as well sometimes offer some migraine patients Botox treatment. Isn't that correct?
Yes.
Why does that work? How does that work?
Listen, this was the way it is often in medicine. You know, nobody expected or even thought or conceived that Botox would work for migraine. It wasn't supposed to work for migraine because Botox is for muscle tension, and that wasn't supposed to be what migraine was all about.
Okay, so the story that has been taught to me in training, and we haven't been doing this for that many years, was that we would, the plastic surgeon or dermatologist, would treat people's muscle spasm or furrows or wrinkles with the Botox to get the muscles to relax that cause the wrinkles. And sure enough, a high percentage of patients came back to their plastic surgeon and dermatologist and say, is it a coincidence, but I'm having fewer migraines or no migraines? Isn't that correct?
Yes.
And then we started doing endoscopic forehead lifts and brow lifts, et cetera, weakening those muscles or stripping those muscles. And some of those patients would come back and say, you know, my migraines went away. So that is one treatment you offer to patients. Now, is it a certain subset of migraine patients, or across the board, migraine patients tend to respond to Botox?
You know, I have such high success rate with the medications that I rarely use Botox.
Okay, so what medications do you use to say prophylax or prevent migraines from coming?
I use, my number one medication is topiramate.
Topiramate?
Topiramate.
Topiramate. Now, does
Yes.
that have a generic name? Is that the chemical name? Does that have a brand name, I mean?
The brand name is Topamax.
Topamax, okay.
Yes.
Okay,
Yes.
so that's your number one preventative medicine.
Yes.
Okay, and what else, can you just tell us briefly, what other medicines might we use to prophylax from migraines?
Well, since the 60s, doctors have used the beta blockers. So just as it was serendipitous that we found out that Botox worked for migraine, it was serendipitous in the 60s that we discovered that Inderal worked for migraine. And it was serendipitous that we found out that putting hands in wax baths or biofeedback to warm the hands worked for migraine. So there are the beta blockers, Inderal and Blocadrin, or Timolol, which works. And then those are FDA approved. And then the third one that was FDA approved was an anticonvulsant named Depakote. And then topiramate came along, and that was originally developed in the metabolic unit of a drug company as a diabetic medication. But all medications go through screening for seizure, and it was found that it was a highly effective anticonvulsant. And doctors, again, serendipitously found that it was highly effective for a headache. And so then it got an indication for migraine before its patent expired.
Dr. Guggenheim, I am fascinated by this, and I hope we can get you on the program again. Unfortunately, our time is running out. Can I give out your phone number? Is that, you're here in Monterey.
Yes.
Dr. Kathryn Guggenheim, neurologist, you're board certified, 655-5151. Is that correct?
Yes.
So Kathryn Guggenheim, neurologist, board certified, 655-5151. Now, do you see patients primarily? Can they call your office? Do they need referral from their primary physician or the emergency room? How's that work?
They can call the office.
If they have questions
Yes.
about migraines, headaches, other questions related to neurology.
Yes.
Dr. Kathryn Guggenheim, thank you so much for appearing on the program. I hope you come again. I guess we're just getting started.
Thank you very much.
This is Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon. We are going to take a very brief pause for a very good cause. We're coming right back.